Welcome to the emDOCs.net Videocast. We'll be looking at summaries of our clinical posts, some takeaways for clinical conditions, guideline updates, and also literature updates. And for our first video, we'll be looking at just that, some literature updates. So for our topics for today, we'll first look at steroids in severe community-acquired pneumonia. Second, we'll look at CT in post-ROSC out-of-hospital cardiac arrest patients. Let's say you're working or starting your shift in a busy ED. You pick up a patient. It's an 81-year-old male with cough, fever, and chills for 3 days. You look at his vital signs, and you're pretty concerned. He's febrile, tachycardic, tachypnic, and his room air saturation is 81%. You hear crackles on the right, and of course, on x-ray, you see a right-sided pneumonia. No big surprise there. Severe community-acquired pneumonia is a fairly common condition. When it comes to community-acquired pneumonia, we see this most commonly in older patients, immunocompromised patients. It's a leading cause of hospitalization and sepsis, so we need to know how to deal with it. For the most part, our management is going to be antibiotics, resuscitation if they need it, but what about steroids for these patients? Our first paper will be the Cape Cod trial, hydrocortisone in severe community-acquired pneumonia, published in New England Journal of Medicine, 2023 May. Their primary question was in adult patients admitted to the ICU with severe community-acquired pneumonia, does hydrocortisone compared to placebo reduce mortality at 28 days? This was a double-blind, placebo-controlled, multi-center RCT conducted across over 30 ICUs in France. They included patients at least 18 years of age who were admitted to the ICU with severe community-acquired pneumonia. There were a couple ways that they defined this. Basically, all patients had a significant oxygen requirement, or they had a PSI of over 130 points. There were a lot of patients excluded. Patients with DNI status, pneumonia due to influenza, those who were in septic shock, those who were aspirated, if they had fungal or TB infection, if they are pregnant, or if they were long-term steroid users, those patients were all excluded. Now, the intervention was hydrocortisone as a continuous infusion of 200 milligrams per day IV with a planned taper for 8 or 14 days, and this was compared to placebo. The primary outcome was all-cause mortality at 28 days. Now, this is an interesting study. It was actually started right before COVID. When COVID hit, the study was paused because the authors decided to start studying steroids in patients with COVID. Once COVID had started settling down, they reanalyzed the results from this initial trial, and they decided to stop early based on what they found. Ultimately, they included 795 patients. 400 were randomized to the intervention, and 395 were randomized to control. The mean age was 67 years, and close to 70% of patients were male. A significant proportion of patients did have an oxygen requirement. Over 40% required high-flow nasal cannula, over 20% were mechanically ventilated, and at least 14% had to have a non-rebreather mask. Also, over 80% of these patients had at least a PSI of 4 out of 5 on the PSI scale. Let's get to the results. So the primary outcome of death by day 28. Hydrocortisone, 6.2%, and in the placebo group, 11.9%. This was statistically significant, and if you calculate the number needed to treat, this gives you a number of 18 for these patients to reduce death by day 28 with steroids. Now, there are some important considerations when we look at these study results. This study does ask an important question. We see these patients on almost every shift. It also looks at a patient-centered outcome. We care about death at day 28. However, this was conducted in a single country, France, which potentially reduces the generalizability. They also excluded the most severely ill, and I'm primarily focusing on those with septic shock. Interestingly, mortality was lower than expected, and an important other consideration is that the trial was stopped early. Now, we need to talk a little bit about we need to talk a little bit about stopping trials early. There are many reasons why this is done. It could be due to futility, they meet a predefined threshold, low recruitment rates, or it could be harm like this trial. Now, in anything with research, we're trying to find truth in the universe. Basically, the point estimate of an observed effect size with a tight 95% confidence interval. The problem is that when you stop a trial early, it potentially overinflates the results, widens that 95% confidence interval, and increases the uncertainty with the trial results. So the author takeaways or author conclusions from this trial was that hydrocortisone reduces mortality at 28 days in ICU patients with severe community-acquired pneumonia with no increase in harm. But wait, we have to look at some other trials here. Paper number two was the ESCAPE trial. This was low-dose methylprednisolone treatment in critically ill patients with severe community-acquired pneumonia, published in Intensive Care Medicine, August 2022. The primary question of the study was in adult patients admitted to the ICU with severe community-acquired pneumonia, does methylprednisolone compared to placebo reduce mortality at 60 days? This was a prospective, multi-center RCT conducted in the U.S., primarily VAs. They included patients over age 18 years and older who were admitted to the ICU with severe pneumonia based on the IDSA or ATS criteria. The intervention was methylprednisolone infusion 40 milligrams for 20 days. Now, just as a refresher, based on those criteria, the IDSA and ATS criteria for severe pneumonia, you need to have one major criteria or at least 3 minor criteria. Ultimately, the investigators randomized 584 patients. 297 were randomized to methylprednisolone. The mean age was 69 years, and the majority were white and male. Invasive mechanical ventilation was used in about a third of patients. Now let's get to the results. Primary outcome, all-cause mortality at 60 days. Hydrocortisone, 16%, and placebo, 18%. This was not statistically significant. It gave an odds ratio of 0.9, but again, that 95% confidence interval crosses 1. There was no difference in secondary outcomes or complications between the different arms. Now again, this study asks an important question. We see these patients almost every shift. They also look at an important patient-centered outcome, all-cause mortality at 60 days. However, this was a VA population which decreases the generalizability. The overall mortality decrease was 2%, but this was not statistically significant, and it was probably underpowered. The author takeaways from this study was that there was no difference in mortality at 60 days with methylprednisolone versus placebo in severe community-acquired pneumonia. Now, these last two trials are an excellent example of publication bias. The Cape Cod trial, published in New England Journal of Medicine, took about a year to get published and it had overall positive results. The ESCAPE trial took 6 years to get published in Intensive Care Medicine, still a good journal, but not the New England Journal of Medicine. Also, it didn't find a statistically significant difference. Also, when you're looking at these studies, no trial is ever just positive or just negative. The ESCAPE trial was probably underpowered. It may have shown a benefit if they had more patients. The Cape Cod trial stopped the trial early, so potentially overinflated their results. Let's look at paper number 3. This was published in Critical Care in 2023, Efficacy and Safety of Adjunctive Steroids in the Treatment of Severe Community-Acquired Pneumonia, a systematic review and meta-analysis of randomized controlled trials, and they did include the ESCAPE and Cape Cod trials. Ultimately, authors included 7 trials with over 1,680 patients. I'm just going to give you the major takeaways from this meta-analysis. The authors found a number needed to treat of 16 for reduction in 30-day all-cause mortality. They also found a number needed to treat of 7 for reduction in need for mechanical ventilation. Overall, pretty good. Bottom line when it comes to steroids in patients with severe community-acquired pneumonia, there is uncertainty, but consider giving these patients with steroids if they have severe community-acquired pneumonia and they're being admitted to the ICU. Of course, there are side effects. You have to be careful of giving steroids for other indications. Basically, what I do is I talk to my hospitalist or the intensivist, and if they want steroids, I'm going to give the patient steroids. Time for a next level point here. It's always tough to determine who needs broad spectrum antibiotics versus just ceftriaxone and azithromycin. Thankfully, there's a calculator in emDOCs called the DRIP score, or the drug resistance in pneumonia score. You input a bunch of variables, and if you have a score of less than 4, you can just use ceftriaxone plus azithromycin. If they have a score of 4 or more, then you'll need something like cefepime plus azithromycin or zosyn plus azithromycin. And I have mentioned azithromycin. It is a very important medication for these patients. This study, published in May of 2023 in Critical Care, Impact of Macrolide Treatment on Long-Term Mortality in Patients Admitted to the ICU Due to CAP, a Targeted Maximum Likelihood Estimation and Survival Analysis, found a significant reduction in long-term mortality in patients who received azithromycin, so give these patients azithromycin. Let's get to our next patient. This was a 57-year-old female found down. She's in PEA and CPR is started en route. The EMS providers are able to obtain ROSC and they come into the emergency department. The question is, what imaging are you going to obtain for this patient? Now, this is so true. We all love the donut of truth. We all enjoy a good CT. Paper number 4 is Diagnostic Yield, Safety, and Outcomes of Head-to-Pelvis Sudden Death CT Imaging in Post-Arrest Care, the CT First Cohort Study. This was published in Resuscitation, July 2023. Their primary question was in adult patients with ROSC after out-of-hospital cardiac arrest, does protocolized head-to-pelvis sudden death CT improve the diagnostic yield in comparison to standard practice? This was a prospective, observational, before and after cohort study that included patients who were successfully resuscitated out of cardiac arrest in the out-of-hospital environment without a clear diagnosis who were stable enough to undergo CT imaging. They excluded patients who were less than 18, they had DNR, there was an obvious cause of arrest, they had severe renal dysfunction, known cardiomyopathy, or obstructive CAD. Now, in the before phase, basically the imaging was left at the discretion of the managing physician. In the after or the intervention phase, patients underwent a sudden death CT with 3 scans. That included a non-contrast head CT, an ECG-gated thoracic CTA, and finally an abdomen pelvic CT with venous phase imaging within 6 hours. The primary outcome was diagnostic yield of sudden death CT compared to standard practice to identify the cause of arrest. The secondary outcome was time to diagnosis, percent correct diagnosis, diagnosis of a time-critical diagnosis, and also delayed diagnosis and AKI. The standard care group enrolled 143 out of 273 patients. The sudden death CT group enrolled 104 out of 307 patients. 84% in the standard care group underwent at least one CT, and that most commonly was a head CT. The mean age of included patients was 53 years. All right, let's take a look at the results. Primary outcome, diagnosis of cause of the out-of-hospital cardiac arrest. 92% in the sudden death CT cohort versus 75% in the standard care cohort. What you see is what you get. There's no confidence intervals calculated. That's it, 92% versus 75%. Secondary outcomes, no difference in mortality, AKI, or identified time-critical diagnosis. However, they did find that sudden death CT was associated with reduced time to diagnosis and delay in diagnosis of time-critical conditions. Interestingly, there was overall better neurologic status observed in the standard care cohort. When we look at this this study overall, it was observational before and after. There were small sample sizes, many were excluded. Unfortunately, investigators not blinded were adjudicators of the primary endpoint. That definitely introduces bias. Also, they didn't look at patient-centered outcomes, and there were no confidence intervals calculated. 2/3 of the SUN-DES-CT group were ultimately not scans, and we're just not sure about how many patients had a diagnosis apparent on initial exam. Author conclusions: SUN-DES-CT scanning early after out-of-hospital cardiac arrest resuscitation safely improved the efficiency and diagnostic yield for causes of arrest compared to the standard of care alone. I think this is a bit overstated. Yes, SUN-DES-CT was associated with greater rates of diagnosis, more rapid diagnosis, but there was no change in patient-centered outcomes. The important EBM consideration here is that observational before and after studies can never suggest causality. They can only suggest an association. Now, this is something I think we can do in the ED, but you need to ask several questions. The first question is timing. You need to make sure the patient is stable before they go to the CT scanner. The last thing I want to be doing is performing a resuscitation in CT. Second, you need to ask where. It is much easier to get this type of imaging done while the patient is in the ED rather than admitting them to the ICU and then they have to come back down to the CT scanner to get all of their CTs. Also, you need to think about where you work. If you work at a single coverage shop, you're transferring the patient out, that's not the time to get the CTs. However, if you work at the center where you're admitting the patient or you work at that tertiary center, that's potentially feasible then. The third question is the type of CT. This study used an ECG-gated CTA of the chest. That's not possible in all settings. My big takeaway is that if you're going to the CT scanner, you can potentially do this type of imaging test. You're going to diagnose more, but you just need to keep in mind that there's no difference in patient mortality. Bottom line, CT head, gated CTA of the chest, and venous abdomen and pelvic CT improves early diagnosis, but there's no difference in survival to discharge. Think about doing this type of CT on the way up to the ICU once the patient is stable. Let's get to our conclusions. For our first video, we looked at steroids in patients with severe community-acquired pneumonia, and we looked at CT in post-ROSC out-of-hospital cardiac arrest patients. Thanks for joining us on our first video, and I hope you stay safe and healthy, everyone.